It is well documented that lung and bronchus cancers are the leading cause of cancer death in the United States in both male and female patients, with lung adenocarcinoma accounting for the highest prevalence of lung cancers. Significant eosinophilia in the setting of lung adenocarcinoma has been described as a rare paraneoplastic syndrome. The presence of this paraneoplastic phenomenon has been recognized as a poor prognostic feature, reflecting advanced disease and dissemination with a more rapid disease progression than expected. We report on an 81-year-old female lifetime smoker with hypereosinophilia associated with metastatic lung adenocarcinoma. For our case, the patient initially presented with a reduced appetite and rapid weight loss, was found to have a right lung mass on a CT chest, and 52 days later, a CT-guided needle core biopsy diagnosed poorly differentiated invasive lung adenocarcinoma with extensive necrosis, as seen in images 1 through 4. 72 days later, the patient presented to the hospital for a left adrenal gland biopsy that was canceled pending further workup due to preoperative laboratory results showing a leukocytosis of 27.9 with an eosinophilia of 6.4. Compared to a negative chest film from 1 year prior as seen in Figure 1, an admission chest film showed a right lower lobe mass as seen in Figure 2. On admission day 7, following worsening respiratory status, the patient was admitted to the intensive care unit and a repeat chest film showed bilateral pneumonia. New laboratory results reflected a leukocytosis of 41.19 and eosinophilia of 4.72. The patient was treated with methylprednisolone 60 mg every 6 hours for wheezing and eosinophilia, resulting in a decreased eosinophil count of 0.0. Compared to a CT chest from 132 days prior, showing a 5.1 by 4.7 by 1.3 centimeter mass as seen in Figure 3, a new CT chest showed the mass measuring at 6.9 by 6.2 by 1.9 centimeters in the right lower lobe with new occlusion of bronchi and pulmonary vessels to the region of the mass as seen in Figure 4. Bilateral lung abnormalities were seen on bronchoscopy, finding a nearly obstructing exophytic friable mass proximally in the superior segment of the right lower lobe. An interleukin-5 level returned negative, and on admission day 11, ICU day 4, the patient experienced worsening respiratory status, and a new chest film demonstrated worsening diffuse bilateral pneumonia and edema. Following unsuccessful high-flow oxygen therapy, she was intubated. After 8 days of intubation, the patient was successfully extubated on hospital day 19. However, given the extent of her disease, poor functional status, and lack of therapeutic options, the family decided on home hospice care. Paraneoplastic hypereosinophilia in lung cancer is usually associated with extensive disease and rapid progression. 2 separate studies, McIntosh and Wilson, found a median doubling time for lung adenocarcinoma of 249 days and 387 days, respectively. However, we observed a much more rapid rate of growth as seen radiographically. While the underlying mechanism of eosinophilia in patients with lung cancer is not completely understood, one theory is thought to be due to tumor-produced cytokines, most notably IL-5, leading to bone marrow stimulation and eosinophil differentiation and maturation. Our observation does not reflect an IL-5-driven eosinophilia, prompting further questions regarding alternative pathogenesis. The need for increased awareness of paraneoplastic hypereosinophilia-associated lung adenocarcinoma is needed due to its correlation with greater disease progression and poorer prognosis. Additional studies are needed to elucidate the actual incidence, underlying risk factors, pathogenesis, and impact of paraneoplastic hypereosinophilia in patients with lung cancer, and there is a need to explore novel targeted therapies for improved patient outcomes.